Okay, good afternoon everyone. Thanks for coming today to today's scrutiny board on adults' health and active lifestyles. My name's Andrew Scopes. I'm a councillor for Beeston Holbeck and I'm the chair of this committee. Just for your awareness, this meeting is being webcast live on YouTube, I think, so you can watch back. If you're watching online, you can, if you just Google or any other search engine the details of this meeting, you'll get the papers that we have in front of us. So what I'm going to do is go round for introductions, if that's okay. So I'll go to my left.
Good afternoon, everyone. Councillor James Gibson. I represent Crossgates and Wimmer Ward.
Good afternoon, Councillor Kevin Ritchie, Bramley and Stanley Ward.
Good afternoon, Councillor Mahaley France Mayor for Moortown and Meanwood Ward.
Good afternoon, Councillor Bromley, Horsforth and Rawdon Ward.
Afternoon, everyone. Councillor Andy Rowntree from Kirkstall Ward.
Good afternoon, everyone. Councillor Taylor from Chapel Allerton Ward.
I'm Jonathan Phillips. I'm co-chair of Health Watch Leeds and I'm a co-opted member.
Councillor Winkage, representing Morley South.
Councillor Conrad Hartbrook, representing Rothwell.
Councillor Lynn Buckley, representing All Woodley Ward.
Good afternoon, I'm Councillor Caroline Anderson. I represent Adel and Wharfdale Ward.
Good afternoon, I'm Angela Brogden, the Principal Scrutiny Advisor.
Thank you. And for guests, start with Councillor Benner, please.
Thank you. Hi everyone, I'm Councillor Fiona Venner. I'm the Executive Board Member for Equality, Health and Wellbeing.
Hello everybody, Victoria Eaton, Director of Public Health at Leeds City Council.
Good afternoon, Alison Kenyon, Deputy Director of Service Development with Leeds and York Partnership Foundation Trust.
Hello, I'm Sam Prince, Director of Operations at Leeds Community Healthcare.
Hello, Phil Wood, Chief Executive, Leeds Teaching Hospitals.
Hello everyone, Tim Riley, Place Lead for the West Yorkshire ICB.
Good afternoon, Caroline Barrier, Director of Adults and Health at the Council.
Good afternoon, Shona McFarlane, Deputy Director, Adults and Health for the Council.
Super, thank you very much everyone, you're very welcome. I think we've got a very interesting meeting coming up, so we'll start with some of the standard items, formalities, so I'll hand over to Angela for those first few items.
Thank you, Chair. Firstly, under item 1, there are no appeals against the refusal of inspection of documents. Under item 2, there are no items for exclusion. In relation to item 3, there are no late items. Under item 4, please may I ask if board members have any declarations of interest? I'll take silence as none, thank you. And under item 5, we've received no apologies for today. Thank you.
Super, thank you very much. Okay, we'll move on to the minutes of the last meeting. I'll start with any points of accuracy that members want to raise. I can't see anyone raising their hand, so I'll take that as agreed. And then matters arising. Angela, can you raise the matters arising, please?
Thank you, Chair. Just briefly, in relation to minute 38 and 39, there were a couple of requests for information that was linked to the Home First programme and Ageing Well. Director of Public Health Annual Report. Just to confirm, these are being progressed. Responses will be provided to board members very shortly. And in relation to minute 41 under the work schedule, just to confirm that the board has recently held a Health Service Developments Working Group meeting on the 3rd of October, and this was to consider proposed plans for the adult mental health high intensity rehabilitation inpatient services. And just to confirm, it was agreed a summary note of the working group's discussions will be shared formally at the board's next meeting in November. Thank you.
Great, thank you very much. Any other matters arising that members want to raise? No, okay, we're going to move on to the first substantive item, which is item 7, which is it's page 15 of our meeting packs, and a review of local impact on national health related policy changes following obviously the governmental change in July. Just going to let Councillor Arif introduce herself because she's arrived, and then I'll pass to Councillor Venner for some open remarks, and then to Tim. Thank you.
Hi, good afternoon. Apologies for being a tad bit late. I'm Councillor Salma Arif. I'm the Executive Member for Adult Social Care, Active Lifestyles and Culture. Thank you.
Okay, so I'll make some opening comments and then I'll pass to Tim. So we suggested putting this on the work programme because of the change in government, so looking at the policy context that we're in. And I think it's really helpful that we've had a summary of the Darcy report as part of these papers. It's a really stark picture of where we are. Just to pick out a couple of things, the additional weights in A&E accounting for an estimated 14,000 additional deaths, deaths from cardiovascular disease going in the wrong direction. So within that context, the Labour manifesto, as it says in the paper, represents three policy shifts: hospital to community, treatment to prevention, and analogue to digital, which I'm sure Tim will talk about in more detail. I do think this shift presents huge opportunities, including for public health and the third sector, because of the focus on primary care in neighbourhoods. But that is in the context of having no money. And the Darcy report highlights that in terms of the pressure on the system, when the report refers to the fact that GPs are undertaking more appointments than ever, and yet people can't get to see their GP. And we've discussed this many times on the Health and Wellbeing Board, and for a long time I thought both things can't be true. We can't be hearing all this stuff from Health Watch about people can't get to see their GP and GPs are working harder than ever. And actually both things are true. It is absolutely the case that GPs are working harder than ever and people can't access them because demand has risen and satisfaction is low. So there's this focus in the Labour manifesto around having a neighbourhood health service, so the NHS becoming a neighbourhood health service. But the Darcy report is clear that that could only happen if there was more investment in the community. There's also reference to social determinants, which is great to see. I don't think it's in the Labour manifesto, but West Streeting in advance of the election certainly talks about MARMA approaches being rolled out nationally and the NHS becoming MARMA informed. And in Leeds, we've got an example of work that we've done as a result of our being a Marmot city, where we've got a social determinants template in public health, in primary care, which supports GPs to consider social determinants of health when they're assessing patients. So that's just one example where what's in the manifesto and what's in the Darcy report aligns really well with what we're already doing in Leeds. And another example of that is the Home First aspirations in the manifesto, which fits with our own Home First programme. There's also this really ambitious public health goal about wanting to create the healthiest generation of children ever, which is great. And the devolved nations in some ways have been ahead of us on this, in terms of in Wales, there's been a Future Generations Commissioner following the Future Generations Act for a long time. It's a very bold ambition given where we are currently, where we are with child poverty, but it does again fit with our own Marmot focus on 0 to 5-year-olds. There's reference to supporting people to get into work, particularly people with mental health problems. One criticism I would have of the Labour manifesto is that it's very light, in my view, on social care. However, there are some real positives in there, in that Leeds is highlighted a number of times as an area of good practice. And I do think the appointment of our wonderful previous chief executive to be a permanent secretary in the Department of Health is sending a really clear message, actually. The fact that somebody from a local authority background has been appointed to that role, I think underlines the commitment to community working, to devolving to regions, and to the opportunities this presents, I think particularly for public health. So, yeah, I'll leave my opening comments there, Chair. Thank you.
Thank you. It was interesting. We agreed that I would bring something back once the new government were in post. And I think what's really challenging in many ways is the breadth of the agenda, not least because quite often when we talk about the NHS, we are actually talking about health, and NHS is only a component part of health. And other times I think we also see, and we often see it in announcements, health shortened to being the NHS. And as Councillor Venner has just said, health is much bigger than the NHS. And I think the role of public health and communities is going to be absolutely critical, as well as that work that colleagues do in the local authority and city council with social determinants. Alongside that, then, of course, there's national policy as well, and I'm sure we'll touch on some of that in a moment. So that breadth is really significant. The second challenge is we're still quite early days. So I would say what we're seeing at the moment is an emerging conversation. There's some very clear direction, and again, Councillor Venner has touched on some of that. That clear direction about a greater emphasis on neighbourhood health, a move towards out, if you like, of acute care to primary care, and so on. Nevertheless, that is still quite light on detail, and for colleagues who work in NHS organisations and myself, the day-to-day running does not always feel as though we're anywhere near that yet. So it'll be interesting to see how that develops over the next few months. And in particular, we know we are expecting an NHS long-term plan of some kind, probably in spring next year. I tend to say in late spring. No one's actually said that, but I've never seen one of these arrive early. So I imagine it will be sort of not quite this time next year, but certainly sort of May or June next year. Even as we were submitting this, in between writing this document and today, there's been the Labour Party conference and more policies emerge. I think one of the areas which perhaps this paper reflects as a weakness is around some of the cross-governmental work that will need to be done in areas like obesity. More of that has emerged, and I think there's a greater sense that government more broadly than just the Department of Health and Social Care is looking at health. That's positive, that's really to be welcomed, and probably wasn't as clear as it is now 3 or 4 weeks ago, but is growing more clear. So in terms of Leeds in particular, as Councillor Venner said, I think there are a number of areas where we have opportunities and where the policies certainly in line with what we would like to do. And I will then I'll just touch on a couple of those and then talk about probably 1 or 2 of the challenges that we face and the government, I think, will face in the meantime. So the move towards neighbourhoods and the focus on prevention is really important. So from a health in its broadest sense and an NHS perspective, both those directions of travel are to be welcomed. We do an awful lot in the city at a neighbourhood level, whether that's local care partnerships, neighbourhood committees, and all those kinds of things that I know go on, and we deliver a lot of services, and colleagues here from particularly LYPFT and LCH have a very strong neighbourhood focus alongside colleagues from Leeds City Council. Certainly as a city, we're looking at how we can strengthen that and be on the front foot. I was with council colleagues at their leadership team meeting this morning talking about precisely this. And in terms of prevention, I think what is really clear and emerging both from the Darcy review and other conversations is the importance of us being really clear what we mean when we talk about prevention. Prevention often in our conversation goes right through from sort of early identification of illness to screening and so on. Secondary prevention, which is often can be medical interventions to lower blood pressure, for example, through primary prevention, helping people quit smoking and so on, right through to social determinants. And it's really important, and I think Leeds is good at understanding the different roles different parts of the city can play in that broad preventative agenda. And we are certainly doing a lot of work in the way we designed our health and wellbeing strategy, the Healthy Leeds plan and so on, to keep that focus on that full range of preventative work. And I know the Marmot piece of work that we're doing is bigger than a piece of work. The programme that we've got really emphasises that and gives some sort of clear direction, as does the Director of Public Health's annual report. The second area, and absolutely with Councillor Venner on this, I think if we're serious about long-term addressing healthy life expectancy, which we should be. Again, Director of Public Health's report really emphasises this. Then we have to be all equally serious about children and children's health. And there's a lot that we are beginning to do together, building on what we've done in the past to take that seriously. Certainly, part of the Healthy Leeds plan, we have got things that are very much geared to considering children and young people. That is probably not always where the attention of the NHS has been more traditionally. It's always felt slightly to one side. So again, welcome the government's initial policy direction in that respect. The other area that the Department of Health and Social Care is really clear on, and where Streeton talks a lot about, is that that all departments, but that includes the Department of Health and Social Care, is a growth department. It's got a commitment to supporting economic growth. And I think that provides us and presents us with some real opportunities, and that's particularly around things from a health NHS perspective, around mental health and mental well-being, but also things like musculoskeletal health and so on. So there's a lot in there. I've not covered it all by any means, that is really positive, and I think we're well positioned to take advantage of going forward. Now, I'll come to the however. However, politically, there are a number of things that we've already begun to touch upon that face the government. One of those is elective waiting times and the waiting lists, both in hospitals and actually in community, and I think that will come to the fore more so in the next few months and years. Those delays are significant, and they are what the public expect from the NHS. So there's a real political imperative to support colleagues across the system to reduce those waiting lists. Those are not about, a lot of those are not about moving to the community. They're about how we support acute care to manage those. Not all of them, but a lot of them. Alongside that, we'll see how winter plays out this year, but again, that can get particularly difficult and draw a lot of attention. And then the other area that Councillor Venner's touched on is access to general practice. And if we're going to be successful in both the short term and the immediate pressures that government and local NHS leaders and others will feel, we have to support general practice and take that forward. It is also critical to that long-term agenda around prevention and neighbourhood health. So there's something that we are going to need to see, and is going to require some considerable effort from national government, I think, in terms of how general practice in particular works. There are other aspects of primary care in terms of things like dental as well, which are not dissimilar. So the Darcy review does not paint a particularly good picture. It paints a picture of a service that is challenged in terms of the NHS, and a society that is also challenged in terms of its health, the way it delivers health and health outcomes. So I think we're in for the long haul, and it's going to be quite important as leaders within the health and care system that we help colleagues understand that this is a direction of travel, and it's not going to be solved by Christmas or indeed by next year. We have a lot of work to do, but overall really welcome the direction of travel, and it is in line, I think, and gives us lots of opportunity in Leeds. So I'm not going to say more. I think probably colleagues will want to join in, ask questions, and other colleagues around the table, I'm sure, will want to add some additional detail.
Okay, thank you. So I'll open up to questions from members. Just, I think I thought, like you and Councillor Venner, that the Darcy report, the summary that's in the pack, was very, very helpful in terms of setting out the situation and what can be done. Just wanted to start on sort of paragraph 16 and 17 of that report, and I guess the capital expenditure, and it's no secret a lot of NHS properties, I guess, infrastructure is probably past its use by date. Just wanted your comments on that, and whether, I guess, how much you think that share in Leeds we need in Leeds in terms of going forwards. And then members, if you want to indicate, if you want to ask a question, that'd be helpful. Thank you.
We know the challenges at Leeds Teaching Hospital. I'll pass to Phil in a moment to talk about those. There are also considerable challenges elsewhere across Leeds in terms of some of our estate. Colleagues from LYPFT might want to mention challenges, although they're more a challenge of NHS financial accounting, I think, sometimes, which makes things more difficult than sometimes it needs to. But the other area is general practice. If we are going to see a shift, and community services, if we're going to see a shift to community and to primary care, at the moment there is not capacity for large amounts of additional work. It doesn't exist. So many GP practices are operating at 110% capacity on any given day in terms of building use. Not all, but a good number. And also, trying to get any money to adapt, change, repair in some cases, that primary care estate is a huge problem. So I don't think we've got a figure on that in Leeds as a whole, but there's undoubtedly, we rightly focus on Leeds Teaching Hospital and the urgency of that, but I wouldn't want colleagues around the table not to understand the significant pressures, and the policy direction will put additional pressure on capital and estates, particularly in primary and community care.
If I may come in on the new hospitals programme position, just to remind colleagues that our plan is to deliver a new children's hospital which will provide children's and young people services for Leeds and Yorkshire and Humber and the North region. Additional facilities for adults, both for the Leeds population and again for across the region. And the merger of our two current maternity units, one at St James's and one at the LGI, to create a single facility. We had outline planning permission back pre-pandemic and also a go-ahead for that scheme. Since that time, colleagues will be aware that there has been a review of the 40 hospitals that were in the new hospital programme ordered by the new Secretary of State. That review includes the Leeds Teaching Hospitals scheme, and we are working with the new hospital programme. We remain confident the review has asked for advanced and ready-to-go schemes which are underpinned by clear clinical strategy, and we're confident that we've kept the same narrative and approach since the beginning of the programme. We've also made considerable progress with our enabling works, demolition and readiness for construction. We don't have a time frame for the report to the Secretary of State, but we assume that this will inform the Chancellor's decisions around funding for the programme that will be announced on the 30th of October, but we continue to work on the assumption that we'll be successful to move forward with our enabling works around that. I think it's worth noting that our current backlog for our whole estate is standing at £630 million of backlog maintenance costs. That's not just at the LGI site, that's across our 5 hospital sites. Clearly the costs of that will only increase with further delays in the decision about the new hospital, and of course the cost of the new hospital itself would be expected to continue to rise as delays continue.
Thank you. I'm going to bring in Councillor Hartbrook. Please, thank you.
Thank you, Chair. Obviously it's interesting and disturbing to hear that hospital programmes are already at quite an advanced stage within city planning of a slip back or under review. It's good to hear that the timescales for review are comparatively short, but obviously while ever it hangs over the city, it does give uncertainty in terms of how we can plan. I just wanted to, Chair, could we possibly write to the Secretary of State and ask for some clarity in this matter?
I'm going to bring in Councillor Venner.
Just to let you know, it'll be published later today. I am taking an exec board paper on this subject to Exec Board next week, which is very much a team leads paper. It's very much highlighting that the council is totally behind our NHS partners in recognising how absolutely vital this hospital is. So, yeah, we're taking an Exec Board paper which includes a recommendation that we make a submission to the Treasury about the importance of this programme before the budget. I would add, though, we have got the review now, but actually this programme has been subject to 4 years of delay. It was agreed in 2020. It is being reviewed currently, and as Phil said, we're very confident that we will still be able to go ahead with our plans, but actually this programme's been subject to delay since it was introduced.
Thanks for that, Councillor Benner and Councillor Hartbrook. It does seem to me that in terms of a team leads approach, just writing something alongside what you're doing, Councillor Benner, can't do any harm, and given the importance of the hospital to Leeds, it does make sense. Yes, do you want to come in?
I was going to make reference to the mental health estate, which is split across inpatient services and community services. And we hold a PFI contract for the majority of the estate that LYPFT use. I don't pretend or will attempt to explain the complexities of the contracting arrangements around the PFI estate, but as Tim has already alluded to, the complexities around NHS accounting have changed, meaning that while we may have cash available to support local development, we're not able to use that. And the availability of NHS capital funding is going to limit the ability of what we're able to do. So it's likely that we'll be inheriting a PFI estate in the longer term that isn't up to the best practice standards that we would expect. As we move more into community-based services and integrate and collaborate with our community partners, third sectors and other stakeholders, it's becoming more challenging around finding suitable accommodation and having suitable estate that we can refurbish to the standard that we'd expect and have the available resources to do that.
Thank you. Okay. Councillor Hartbrook, do you want to come back on the point about the Children's Hospital? Are you satisfied with us writing? Great, thank you. Good. It might be that I'll ask Angela to write to you, Councillor Benner, just to make sure we are consistent in our messaging as team leads. Good. Okay, Councillor Anderson, do you want to comment on this as well, please?
Thank you, Chair. Just to echo what Councillor Hartbrook said, I think we should write as a scrutiny board to say we're very concerned in Leeds, and I really don't understand why our programme ended up on that list at all. So yes, I would second that. Thank you.
Thank you very much. Okay, I'm going to bring in Councillor Gibson next.
Thank you, Chair. I just wanted your thoughts really on how achievable the sort of shift towards preventative sort of healthcare is. I'm conscious that there has to be a sort of a buy-in from the public, and that seems to have been so for things like, for example, active travel or eating healthier, balanced diets, and that element of preventative healthcare. And it seems to me that that's sort of been undermined quite a bit by some, well, quite vocally in the public. Even things like, you know, whether or not we should be promoting unhealthy foods on television or smoking. You know, it's often deemed the nanny state when the government tries to intervene like that, quite unfairly in my view. So I just wondered if it's with that sort of resistance sort of building up in certain parts of society, whether it's achievable to get the community buy-in or the public buy-in that's needed to be able to have this shift towards preventative healthcare.
Thank you. I'll go first. Councillor Benham may want to add. So it's a great question, how achievable is the shift to prevention, and there's lots of different parts of that. I mean, as Tim's alluded to so far, the there's different kind of blocks of prevention we do. So the stuff you've mentioned, Councillor Gibson, around being very much around creating an environment where people find it easier to make healthy choices is, you know, around that food environment, etc., is one of those. So just on that one, I think it's interesting that over the years and now decades, it's pretty well understood now that taking an individual kind of behaviour approach doesn't work in terms of healthy weight of populations. We had the healthy weight session here, and obviously kind of we had a good conversation about the need for kind of environmental approaches as well as supporting people individually. So my understanding is that even the most hardened kind of opposition to sort of perceptions of nanny state have now appreciated that this is where we are, and we're just never going to shift it if we don't do something on a more macro level. So I think things are now on the table around, you know, pushing back quite hard on kind of commercial organisations that you know, make it very difficult for people or incentivise unhealthy choices. I think this is now firmly in the territory of where the vast majority of people from all political persuasions understand the evidence to be, and we would certainly support that from a kind of a professional advice point of view, that we're having to get into those kind of spaces now where we really take on food environment rather than just sort of work individually with people, even though we need to do both. So I think that that's where we're up to in that direction of travel on the wider environment for people in society. I think there is, in terms of the prevention work, even within our NHS, there's still, and Phil might want to, or others may want to comment on this, but there's still a real issue of the resource envelope and no new money. So we know it's very welcome to see commitments to shifts from treatment to prevention, which we've had for quite a long time now. But it is really looking at how you translate that into a kind of resourced reality and what that really looks like. So even within the NHS as a system, I think there are real challenges to seeing that prevention come to fruition, because the money's got to come from somewhere else. But like I say, in terms of the broader stuff in society, there's a declining opposition now to knowing that we need to do something much more systematic. Thank you.
Do you have a follow-up, Councillor Gibson? No, that's a really helpful answer, Victor. It's something I was also interested in asking about, and I think there's a real challenge in that. We've talked about this before in terms of demographic changes of our nation over time. It's going to mean even if we prevent, it might appear that things are staying flat in terms of rates, but it doesn't necessarily mean prevention isn't working, because as we age more, we'll present with more different challenges. Victoria, do you want to come back?
Sorry, can I just come back on one thing? Because the national policy context conversation feels really interesting on this one. I think it's just worthwhile sharing with this board around what's looking like the relationship between those three drivers within the NHS, those three shifts which Tim's talked about, and then the focus of the big agendas that we should be really looking at across government, which will make the most difference to it actually improving health, which will include work with the NHS, but actually is complete cross-government work, and for us, cross-city work. So the big agenda, I mean, obviously the tobacco and vapes bill is going through Parliament now, and that was always seen to be the absolute priority for making the most difference in health. So that's making its way through Parliament now. The second one to follow will be a systematic focus on alcohol harm. And then the other big ones on that list for cross-government action include healthy weight, obesity, increasing physical activity, mental health and suicide prevention, and air quality. So this is very strongly driven by Chief Medical Officer and public health advice on the issues we need to address to make the most difference to health. So I think we can start to see these coming through nationally, and there's a call to action for local health and wellbeing strategies and plans to reflect those areas where we know we can make the biggest health gains. So I think that's just something to be aware of. Thank you.
Thanks for that, Victoria. Councillor Gibson.
Thanks for that. And look, just to put my cards on the table, I think this is exactly what we should be doing. We should be moving towards a prevention model. I've always thought that, and I'm glad to see that it's finally filtering front and centre into international policy. But I just wondered whether your interpretations or your assessment, do you think as a society with the arguments there, we're ready for it? Because, you know, there's some tough choices around if we are shifting towards, say, primary care, more GP surgeries, that might mean less hospitals. And you know what a crisis that creates if you ever suggest not building as many hospitals, for example. And I have heard those sort of discussions bandied around when there's been conversations at a national level. Do you think as a society we're ready for that? As the argument there, the public buying into this model? I'm interested to hear what you think.
Yeah, thank you. Really good challenge, a really good question. I'm sure Phil and other colleagues who, perhaps Alison from a mental health point of view could also respond if they wished, but I wonder whether the real question is whether we need fewer hospitals or smaller hospitals, or actually what we need is less pressured hospitals. So I think the challenge about how the money moves is a really important one, and I think that's where we get into this policy detail. When we look at the demands on our acute services, whether they're mental health or physical health, they are huge. An improvement in the health of the population will make them more manageable. That is a very different thing from less hospitals. It means a more manageable, higher quality offer, possibly, but it doesn't mean we're able to close hospital beds and so on necessarily. But I do. What I also like to just say is I don't want us to lose sight of the fact that very often clinical and professional staff are highly trusted still in those relationships, and this emphasis on prevention and lifestyle at that end and the secondary prevention end that the NHS can be part of can very much be part of the agenda without necessarily requiring huge amounts of money. It's more how we work with our staff and ensure they have the space to do it. I don't think there's a simple answer to this, but I do believe we have got some answers. But Phil and colleagues may disagree, but I feel it's less about numbers but about pressure.
Yeah, thanks, Tim. No, I do agree with that. I mean, I think the pandemic international evidence showed us how under-resourced we are in terms of hospital beds per head of the population, which is partly why our hospitals are so overfull and relatively inefficient as a result of over-occupancy. I think as programmes such as Home First have illustrated, actually it's about team leads working collaboratively to ensure that people are getting the right care in the right place. A hospital will have a role, particularly as we have an ageing population with multi-disease challenges, increasing rates of cancer, early detection of disease, and a hospital intervention may be an appropriate point of that. But the key thing, as we've demonstrated with Home First, is to ensure we're offering people the right location for the right interventions that they need.
Yeah, Sam, do you want to come in next?
So I would agree with that. There's always going to be a need for hospitals. We just need to make sure that the people who are in hospital are the ones that need to be there. And I think the Home First programme, along with many other programmes that we have in Leeds, are trying to keep people out of hospital. So if we look at prevention in its widest sense, it's about keeping people well at home, enabling them to have the access and the ability, the skills to look after themselves, So our investment in Leeds Community Healthcare around self-management has been really significant in helping people to stay well at home, and that's something that we can do as part of any interaction with patients. So it may be that they come forward for some kind of specialist intervention, but that making every contact count, thinking about prevention messages, thinking about self-management messages every time is what turns the tide in public opinion, because they start to see that following that advice, using those skills, is a way of keeping them out of hospital.
Thank you. And Alison?
Thank you. I'm going to echo what Phil was saying around the way our kind of inpatient facilities operate. It's not the most efficient way, it's not the most effective. You'll be reading in the Winter Plan paper later on about the pressures within mental health services, inpatient services, and the emphasis really from a lot of the work that we're doing, particularly through programmes like the Community Mental Health Programme, our transformation programme, are about how we might prevent, somebody getting to a stage where they need to have a hospital admission. But I think the thing we must remember about when we're talking about moving resources around mental health services, that I was reading the other day, I think it's mental health activity accounts for over 20% of NHS activity, but actually mental health services receive less than 10% of the NHS budget. So there's that historical imbalance that we've really got to deal with when it comes to mental health services.
Thank you very much. Okay, I'm going to bring in Councillor Ritchie next.
Thanks, Chair. I'll just start by giving my comments on Councillor Gibson's question around public perception and picking up those preventive measures. And referring to later on in the agenda, when we look at the vaccination figures, that worries me, that perhaps that those messages of prevention aren't getting across to people. So I kind of share if there were concerns. I know you asked an open question of Victoria, but I'd be slightly worried based on things like vaccination, which are crucial for preventative and good health, aren't they? But moving on to what I was going to talk about, first of all, really welcome the report from the Lord, what's he called? I forget his name. Darcy, forgive me. I think it's Councillor Venner. I won't repeat what Councillor Venner said because she picked out some of the areas I picked out as well. But what I would say is I think it's helpful in perhaps correcting some of the myths that are out there, what I call the lazy tropes that we see on social media or some politicians around there being too many managers. That's the fault, they tell us. The cost of our system is unsustainable, and again it covers that, that it's the best value for money paid by taxation and free at the point of use. And he also praises the staff for the quality and their expertise as well, because I've seen comments again as though he's had a go at the staff, and I don't think he has. So I think it's a really important report. What is key through it is the disaster that austerity's been for the NHS and the health of the nation, and that comes across loud and clear, and I hope the next government will take that on board when formulating future budgets. Now on to some of his findings. I just wondered around bullet point 13 when he talks about the need for that budget shift. Do you and this ties into again what we're told there's no money. Again, I'd question about how much money there is in this country. I accept the government set fiscal rules, there is flexibility around that, but based on where we are with the fiscal rules as set, and if we accept there's no more money, do you think it's feasible to do a shift straight away, as it were, from that budget, or with the pressures that exist in secondary care, as you've said, the elective surgery make that impossible, so you wouldn't be able to take any money away as we are now? I think there's a strong case for investing in more money, and in his finding number 14 around improving the nation's health to benefit the economy. It's a massive persuader of like we have at the council and the hospitals as well around Investor Save. It's a no-brainer really. And I'm sure that Tom will be taking that to the heart of government as well, having led on many of those initiatives in Leeds. And then just a question on finding number 19 around patient engagement and the cost of claims. I think it's 3 billion, is it, or £3 billion in claims. It's not clear in the report whether they're saying there's a direct link to poor patient engagement and those compensation. Now, in Leeds, I believe we have strong patient engagement. We've got Health Watch. I know the learning disability team do some fantastic work engaging with the community in Leeds. So is there a link between patient engagement, and is that reflected in terms of where those compensation claims are throughout the country? For example, is Leeds lower than other areas, for example? I think that's it. Thank you.
So I think there's at least 3 questions there. I don't know who wants to start. Pass over to Tim. Yep.
I just wanted to start with the question around the money and without investment, because I think we'll keep coming back to this. I do think there needs to be some investment to get things started, but I'm not sure it initially is as big as we think it is. And the reason I say that is that sense of a virtuous circle. We can invest fairly small amounts, and have done over the years, in schemes and in areas which do have an impact. Interestingly, we talked about Home First. There was very little additional investment. If anything, that's been money coming out, because we've worked things through in a better way. Now, what it did need was a small, in global terms, a relatively small amount of money initially up front to get the momentum. But once that was done, we actually then seen financial benefits. So I'm hopeful, and I'm looking really for government not necessarily to do something grand, but if we have opportunities to invest in prevention, in earlier identification of disease, those kinds of things, then I think we can make a difference. So I don't want to be entirely pessimistic, although I do have days where I feel a little bit like that. I think there are opportunities for a city as ours that works well together to take hold of that and make some difference. I've got to be honest, I don't know the answer to the question about how we sit in terms of claims against us. It'll depend from different organisations, and we probably don't have that data with us at the moment collectively in Leeds. I think there's an interesting conversation about patient engagement in the way services are structured and delivered, and then the individual's experience of care and the consequences of that. Claims is very, very much linked to that last point around the individual's experience. And colleagues who work in delivering services are going to be much better in some ways at picking up how well we do that as a city in Leeds. But there's undoubtedly a connection, but I wouldn't want us to see the connection entirely about how we engage the population and the public in designing service offer and what's then experienced in terms of the care that they receive, which is where the vast majority of claims sit within our system.
So just on that, Tim, when I asked about this point, you explained where a lot of the claims came from. I think that might be interesting for Councillor Ritchie as well.
Did you want to come in? I'll let Phil answer.
Yeah, thank you. So I think specifically on the complaints and claims issue, I think some of that quite rightly is related to rising expectation of what should be delivered in our health system, and I think that's entirely fit and proper. The highest percentage by a considerable margin of that overall figure relates to maternity related claims, and committee will be very aware of the national scrutiny of maternity services nationally and some of the negative media that's being put forward. Worth noting that Leeds maternity services were rated good by the Care Quality Commission, one of the very few in the country to achieve that. And Specifically for maternity, we do know that our claims relatively are low in Leeds for the number of births that we provide for the city compared to the national average.
Kevin, Councillor Ritchie, do you have a follow-up question?
No, I think that's mostly covered. Just, you mentioned bringing in extra money, but my point was around, so if you've got your £1 billion, if you would it be feasible to cut, say, by 20% your NHS budget and put that into primary care, or would that then cause additional pressures on the NHS?
I think some of the reflection that we need to take from Darcy around the relative inputs of funding across the NHS, which is distorted, as we know from that report, in the UK compared to other countries. Some of that relates to, I believe, the targets that are set for some parts of the system but not others. And actually, he comments in his report, as you'll have seen, about creating the right financial flows to ensure that we are moving resources in the right direction. And from secondary care, we'd be fully supportive of understanding what that would need to look like. I think, as Tim mentioned about the Home First programme, effectively we have shifted resource by undertaking the success of that programme. So that's been an indirect way of moving resources from where they were being spent in the wrong part of the system to the right part of the system. So actually, I think it's unlikely that you would take money away from a certain part of the sector without destabilising it or increasing pressure on it. But there are ways of ensuring that collectively, which is why I think Leeds is in such a strong position, of spending our health and care most wisely where it's most needed.
Thank you. Victoria, do you want to come in as well?
Yeah, thank you, Chair. And just to add, and it does go back to Councillor Rich's earlier reflections on the kind of public appetite for, and do we need to do more work on with communities on kind of understanding this debate and the debate about what impacts on their own health. I think for me the answer is yes. There is this conversation around expectations for what can be achieved by more and more resource into our NHS and how that relates to the health of our communities. So we know that at the most the NHS will be responsible for about 20% of the health of our city, the health of communities, and then 80% of what makes people healthy is created outside the healthcare system. So we rehearse that all the time as partners. So we're clear around roles and who does what and how we manage that. But I do think that kind of public expectation that if you keep funding more and more into healthcare services, it will give you that 100% impact on health, when actually we know that's not the case. So I think there is something around keeping that dialogue open with people around expectations of the things that can help them to stay well throughout their life and for their families to stay well throughout their lives, and actually having really great healthcare when they need great healthcare, but that's not the thing as creating great health in a place. And it's that separation, again, Tim did it before, around healthcare, including the NHS, and how we create good health in a city, which are very, very different. And the more that we fund one bit of the system, the more we disinvest in another bit of the system. So we know that sectors such as education and housing and access to green space, etc., they've all had to take the hits in the public purse because we only have so much money. So I think to continue a conversation with our citizens around the place of great healthcare as part of how we are a healthy city is really important. I think that often slips back to defaulting that the NHS can deliver all of this all of the time, which of course is completely unrealistic. Thank you.
Thanks for that, Victoria. Okay, I'm going to move on to Councillor Rowntree.
Thank you, Chair. To some extent, the primary question that I wanted to ask has been covered by Councillor Ritchie and the replies that people have given to him. But I was a little troubled looking at the concept of a transition from hospital care to primary care and neighbourhood services, with the thought that we've already said today that we believe GP practices are working to capacity and beyond capacity. It's not like there's a spare capacity there. And I'm just troubled by the idea of the impact that sort of reducing provision in the hospital sector might have. I mean, clearly there isn't, I'm sure, a great deal of spare capacity in hospital operations at the moment, and I'm just thinking, how do we get the transition going without massive injections of capital? I'm thinking of the pain of sort of skilled people. Will you be moving sort of highly qualified people out of hospital into different neighbourhood environments? And this, I mean, it sounds obviously like an extremely long-term operation. How do we get this kind of thing moving, and how do we manage the dislocations that go with it? Thank you.
If there was an easy answer to that, I think we'd have done it, because we were all very up for that conversation. And there is going to be need for some national detailed policy around that, both more broadly across government, but also in the Department of Health and NHS England, I think, to support that. I do come back, though. We did a little bit of work recently where we've looked at, for example, numbers of people towards their end of life with respiratory illness that are then using acute hospital services, including inpatient stays. There are very few people at the end of life who would like their last days to be spent in hospital. But nevertheless, that's still a relatively high number. So it does go back to right care in the right place. We then did a detailed look into about 9 cases with a whole set of professionals around that conversation. And the outcome of that was we thought 7 of them shouldn't have ever got to hospital. And what we needed in order for that not to happen was relatively tiny compared with the amount of money that we would need to spend to look after them once they did. And so there's now a conversation and a set of pilots just to see how we can do that. So sometimes we look at this shift as very big, and actually it's about individuals, and it's about individuals' care, and it's about how we coordinate care together in local areas, neighbourhoods, localities. It's not necessarily about fundamental big change. I'm not saying there isn't any, and the Home First programme is a good example of where there has been a shift. But again, it started with those cases and those individuals and working it up, rather than saying, well, we need to move that bit of money from there to there and then it'll all work. We actually did it. So it's quite a nuanced and sophisticated, and someone commented about managers. Appreciate that. As a manager, it takes management to organise some of this, and it's hard work and a lot of conversation across multiple partners, including engaging with public and the carers and so on. So I'm not naive that it'll be easy, but I think we've got some good examples in Leeds of work that we're doing that starts with individuals, residents of Leeds, and when we look at that, we can understand what the better offer should be. I hope that it's not a complete answer, because otherwise we would have solved it by now.
Thanks. That's very helpful. With your study there, you identified it would have been desirable to have delivered care to these patients in a home environment rather than the hospital environment. Would that mean a translation of staff, like the same people supporting the patients in in the home environment, perhaps to a lesser extent. What would the implications being for highly trained staff? That's what I'm thinking.
Thank you. So with both respiratory care and with frail populations, we've had what are termed virtual wards. Nobody likes the term, but that's the term we were given nationally. But this is a multidisciplinary team from primary, community, secondary care, social care coming together to discuss the best way of delivering care for a patient. So for respiratory patients, for example, our consultants still remain working in the hospital, but they participate in conversations about how to manage patients outside the hospital. And I think these are the models that will grow. I think we've got an item later on the agenda which will also demonstrate the work that's being done around thinking around a health and care workforce for the city rather than thinking around organisational silos. So I think there is a lot of small-scale work, and the key is to try to upscale that work around how individual teams can come together around the needs of a patient rather than, again, thinking about moving staff from one organisation to another.
Yeah, great. Just again, I know you mentioned the Home First a number of times. Again, when they talked about Home First last time, one of the things was staff survey, and I think initially those initial consultations about the changing in the work dynamic were not necessarily easy, but over time that progressed. So I think there is, again, a good story to be told there. Okay, I'm going to bring in Jonathan next.
Thank you, Chair. One of the three elements of the government's policy that we haven't touched on yet is the shift from analogue to digital. And there's obviously a huge amount of digital stuff that needs to be done in terms of diagnostics and all of that. But then there's the access side of it. And we've talked about this before, and you touch on it, Tim, in the paper around one of the weaknesses is the risk of increasing inequalities between those that can access services digitally and those that can't. And so it'd be interesting to know on the first part how well we're doing around adopting digital skills and capacity around the whole sector. But secondly, whether you think we're doing enough to mitigate the risks of people being more excluded, and whether there's scope for a more strategic approach right the way across the system to try and manage and handle that and reduce that weakness, that risk that you've identified.
So in terms of the sort of first question, where is Leeds up to? I think.
Sorry, Jonathan, can you just turn off your microphone? Thank you.
Thank you. So in terms of where Leeds is up to in terms of that shift from analogue to digital, I think we've got some really exciting examples of where we are doing that, the right kind of things, some of the work that we do in the hospitals, some of the work we have around the Leeds healthcare records, some of the work that supported Home First actually required that sort of digital back wiring in a way that perhaps we had not done before. There's a long way to go. It does go back to the capital question, because some of this really does require significant investment. And as the Darcy report clearly indicated, it's one of the first budgets that gets raided nationally and indeed sometimes locally. So we are not where we would need to be, but I think Leeds is in a good place. Not 100%. Leeds is in a good place around digital inclusion because of our investment. You know, we've got a digital inclusion team hosted within in the Leeds City Council, but funded in part by all of us because we recognise it as an issue. However, I think what happened was COVID, in particular, escalated at a pace that the public couldn't keep up with the use of digital, particularly around access. And we've been working hard to catch up, but we've had to catch up in a very, it's been very fast. I look back and think about the change, say, in banking. Well, it happened over years, actually. We moved to more and more digital banking over a very, very long period, and still people were excluded. The NHS actually moved in about 6 months. And I think that there are communities, undoubtedly, that have not kept up. So I'm not adverse to your suggestion, John, that we need to perhaps think a little bit more strategically. What I wouldn't want colleagues here to think is that Leeds is not in a probably stronger position than many places, partly because of the work the digital inclusion team and the colleagues and some of the third sector, because it's money's routed through them, but it often is third sector organisations that are delivering some of the support around that. So again, we're probably in a better place than some, but that doesn't mean we've cracked it at all. And I do worry still that there is a real risk that we will keep pushing on this agenda at a pace that the public are not able to keep up with. And we definitely saw some of that in COVID.
Thank you. Well, I mean, I do think it would be worth, therefore, obviously, outside or maybe this board requesting that we have another look at whether we're being as fully strategic as we could be across the whole system in relation to mitigating against exclusion for the very reasons that you were saying and that you've identified.
Thank you very much. And I think there's a fair question there also around how joined up all the NHS systems are. But I think that's a much bigger, more complicated system because the NHS is a big provider, and I understand that GPs have different systems to hospitals who have different systems to each other sometimes. But yes, that is noted by Angela. I saw making a note, so that's good. Okay, I can't see anyone else indicating to ask a question. So I'm going to close this item. Really helpful report, so thank you for that. And I think that I think also the appendix of the Darcy summary I thought also was really helpful, and so thank you for engaging in those conversations. I understand that I think you and Phil need to get to another meeting, which you're welcome to, and I think there's a couple of people in the audience who want to come up for item 8, so feel free to do that. So I'm going to move us on to item 8, which is health and care workforce in Leeds. I'm going to start just by saying, first, we talked about this last year, October 2023. This is a really important item, and obviously to manage all the services that we need our staff. We need staff to be doing it, and frontline staff are very much in need, as are back office staff. So I'm going to pass over to Councillor Venner for some introductory remarks. Thank you. And then after that, the people have come up. I'll let you introduce yourselves. Thank you.
Yeah, thank you. So this is a really important report following on from the last report in that, like the Darcy report's really, I think some of his language is very eloquent and also very blunt when he talks about how sick the NHS is, but he describes its vital signs as being good. And the report talks about a workforce that's burnt out, that's traumatised from COVID. He talks about high sickness rates, but he also talks about a workforce that's made up of highly skilled clinicians and people who are absolutely passionate about the NHS. So in the light of that, this is why this report's really important, and it follows on very well from the last report, because this is our update about how we're meeting the workforce challenges in Leeds, including how we're tackling reducing health inequalities, such as the work where we target specific communities in areas of deprivation to really proactively try and bring people into careers in health and social care. The report includes the third sector workforce, which is a really significant part of our health and care workforce, but also a part of our workforce that's really under duress at the moment. And being blunt, that is because both the council and the NHS are having to make cuts to the third sector as part of our own ongoing financial struggles. So the third sector is really important, but also under the same stress that every other part of the health and care system is. The work that's being done around workforce really is about meeting our aspiration to have a health and care workforce that's inclusive and that's well trained and that's positive about their work, and where we have an ongoing pipeline, particularly to meet the ongoing challenges that have been talked about in terms of that move from hospital to community, from treatment to prevention. So I'll leave my opening comments there. Thank you.
Thank you very much. Kate, do you and your colleague want to introduce yourselves, and then if you want to make any opening remarks, you're welcome to do so. Thank you.
Thank you. Hi, I'm Kate O'Connell. I'm the Director of Leeds Health and Care Academy. I'm the Strategic Lead for Health and Social Care Workforce across Leeds.
Good afternoon, everybody. I'm Jenny Lewis. I'm Director of HR and Organisational Development in Leeds Teaching Hospitals. But I'll twin hat today because I'm also joint exec sponsor for the Leeds Health and Care Academy with Caroline Barrier. So I'll wear both hats.
So thank you very much for that introduction, Councillor Venner. So we last came to the Scrutiny Board about a year ago, so wanted to share with you through this paper some of the progress that we've been making across the last year. I think it's important to recognise that lots of the work that happens across system, particularly in the space of workforce, is quite a slow burn, so it takes place across a period of time, and you have to really understand the interventions, the impact that that's making in the broader context of what's happening externally as well. So just to give a flavour of the last year, I think we've seen and we've heard already this afternoon about the kind of significant financial pressures across health and social care in all aspects of delivery, planning and understanding impact as well. And also the operational pressures certainly haven't got any lighter, and we're seeing that focusing in the acute sector, but very much through primary care, community and mental health as well. And then not least to say about the diverse provision in social care. So really understanding the connections through right back out into the community, but that social care workforce being absolutely critical to everything that comes at that more acute end of the spectrum later on. So having said that around the financial and operational pressures, I think we have seen a shift over the last year from that very sharp kind of focus of COVID recovery into a much broader understanding of the impact of the cost of living pressures and some of the financial issues that members of our population have experienced as well. That said, I think our staff risk across the system in health and social care is relatively stable over the last year. So it's not good. There are definitely areas of real pressure and real risk in terms of staffing capacity, skill sets, etc. But what we haven't seen is the volatility that the COVID period brought us around those staffing risks. So that's really kind of helped shape our approach across the city, bringing organisations together to try and focus on what the population of our city needs in terms of workforce. And it's brought with it a slight shift towards a stronger focus on workforce retention as a system. So rather than thinking necessarily about that attraction and trying to grow capacity and get lots of people into workforce, it's much more about how do we retain the skills we've got and think about where they work in the system, so helping that mobility around the system. We've also seen a real focus on supporting service development and service change. So you've heard a bit already today around some of the key initiatives like Home First. That's been really critical, thinking about that earlier question about how we move staff and skills around the city in a way that is not disruptive, in a way that doesn't cause distress for the people who've trained for a particular career and feel that they're being dislocated in some way. So that's been a real focus of this last year. And more generally, reskilling. So we've heard about some of the changes around technology and the pace at which services, technology, digital things are changing the way we work, and really thinking about how do we support staff wherever they work to really make the most of those potential opportunities that brings, but feel confident with it as well. So it's building that confidence to be able to make the most of those. So I won't go through the policy changes significantly because that was the previous item, but I have to mention the Darcy report because it does talk about workforce quite significantly throughout that report. And I think in a way that's quite helpful for some of the reframing that we've been doing in Leeds for some time. So a very strong focus on staff voice and the importance of staff voice in how we change and how we work together. A real focus on multidisciplinary teams and working as collectives and collaboratives and not just relying on professional silos or groups. Technology and digital, and a really important one around the stability of management. So really welcome the fact that it's not about blaming management and you know, taking what feels like a kind of quite well-rehearsed argument about management within the NHS and local councils, but actually thinking about the importance of stability and evolving and inclusive leadership and bringing those key managers on that journey as well. So within Leeds, we've looked at, over the last year, finalising the 2031 workforce strategy, which is a continuation but an evolution of the strategy we've had in place for the last 5 years. And that's a real kind of refocus of commitment to work together. So that is all of our NHS partners, the local council, our third sector representatives, primary care, independent providers, really thinking about how do we work collectively across the workforce to support our ambitions for Leeds. And it builds on a lot of the achievements over the last 5 years, but takes a lot of learning as well. So we know that we've still got lots of mountains to climb and things that we can do better. We've been looking at impact over the last year, and that's presented in the report for you, and you can see more detail in the annual report of the Leeds Health and Care Academy. But I just wanted to highlight a few things because I think it's important to give a flavour of the change that we're actually making on the ground, not just what we can write on a piece of paper. So one of the big innovations of the last year has been the launch of the Career Compass Leeds, which took place last week. And this is that real sense of connecting our future workforce into health and social care of the future. So that's been really collaborative work with schools, with colleges, with the universities in Leeds, working with Employment and Skills Service, recognising some of the challenges for diverse communities accessing health and social care roles, and helping take a kind of person-centred approach to that. And that's a digital platform which is now live, being used by careers advisors and open access to the public. We've also had a real focus on quality and best practice, and you'll see in the paper reference to our collaborative T-levels and apprenticeships. They remain really high profile nationally in terms of what we're doing in Leeds, because we're not taking a traditional professional focus to those routes, but we're actually working in multidisciplinary and multi-organisational capacity to build those sustainable pipelines. I'll flag something around investment and efficiency as well. So by collaborating around workforce across Leeds, we have the opportunity to attract in investment that's beyond the usual public sector funding. So you will see in the report we've been successful this year in attracting funding from the RAIN Foundation, which is an organisation we're working in partnership with now to develop a programme around better careers for better care. And it's only because of our collaborative working in Leeds that we're able to get that additional investment, which actually makes a difference on the ground in terms of what we can deliver. And then I just want to say a little bit around the people impact, because we talk a lot at the kind of macro level, particularly at board meetings and things like that. But actually, where we really get the depth of insights is from understanding the impact on individuals. So we've recently shared a case study of a member of the workforce now who is called Shogik, who we can share the link if you haven't seen it already. But she was an individual who applied to work in Leeds Teaching Hospital as a care support worker, but was unsuccessful at interview. And rather than just sending her a letter and saying thank you for your application, Leeds Teaching Hospital referred her into the Talent Hub, which is part of the Academy. So with one-to-one support through the Talent Hub, we identified where her challenges were, worked with Employment and Skills in the council to secure her support through the Multiply programme, which enabled her to get a tutor to support with maths skills. Having completed that work, she's successfully upskilled in maths. We continued to work with her through the Talent Hub to support her into a pre-employment programme. She successfully went through that pre-employment programme And through that, we linked her back in for a further interview with Leeds Teaching Hospital through the Talent Hub, and she was successfully appointed as a care support worker in Leeds Teaching Hospital several months later. And that wasn't the end of her story. So she came back to us to talk about the impact on her children and how proud her children were of her and how they'd taken her story into their school to tell their friends and their teachers about what she'd done and how proud they were of her. And beyond that, she found the self-confidence to apply for a BSc at University of Leeds, where she's actually been accepted, and she's just started studying now part-time while still continuing to work as a care support worker. Now, her case study for me tells me everything that I need to know about why we do work together, because in any other city, I think she would likely have been lost at some point during that journey. But here, we were able to create the environment and walk with her to that successful end. So I think that's really what I wanted to say. I think the role of carers in third sector is a really important part of that story. It's in the report, and Councillor Venner mentioned the importance and the pressures that the third sector and carers feel within Leeds. We do a lot of work to support that from an infrastructure perspective and recognise that workforce, whether it's paid or unpaid, is a critical part of our system, and they bring specialists and expertise, particularly to work with Talent Hub and other collaborative projects. So I will leave it there, but happy to take questions and observations. Thank you.
Thank you very much. Really helpful work and really exciting story. I think that brings to life what's going on. So thank you for that. I'll open up to questions if members want to indicate in the usual way. So I'll start with Councillor Ritchie, as he's indicated straight away. Thank you.
Thank you, and thank you for your summary there. And I did watch the video. We were sent the YouTube link, and it was a really interesting, powerful way of getting it across. Just a question on what you've added to it, because I'm intrigued. This person got to an interview. Is there more flexibility on who gets to interview? In some ways, because it were maths and English that were the weakness, the first sift might have got people out of the whole system. So are you taking a bit more of a flexible approach in getting people to interview with this Talent Hub in mind? And also, how wide is the Talent Hub referral? So would every applicant be referred, or is it just people who get to interview? So that's the first question. The second question is around the workforce indicators and the work around, I'm going to focus on disability. There's no actual detail of how that's progressing, but I just wondered if you did have any figures on how you're getting on with recruiting more disabled people and giving them those opportunities, and are you utilising the access to work, and are all organisations signed up to the reasonable adjustments? I know that's the law, but that's not necessarily what people's experiences are. So is there a real commitment to that and that flexibility to get those people into work who will be a real asset to the organisations, I'm sure? Thank you.
Thank you. Yeah. So I'll start with the first question about the referrals. So individuals can refer themselves to the Talent Hub, so it doesn't require a third-party referral. But what we found works really well is the relationships we've got across employers, particularly, and the colleges and universities, to have that proactive conversation with them around, what are your big campaigns at the moment? What are you recruiting for? What's the appetite? What kind of numbers of candidates are you getting, etc., and prompting some of those. So it does require a bit of that proactive relationship management as well. But all of our statutory organisations, so NHS and Council, now have processes in place to refer candidates on where they're good candidates, but perhaps don't meet a specific criteria or something where they feel that the Talent Hub could help. I think one of the key factors has been a real shift to values-based recruitment across the city. So what we've seen, I think, historically is quite a mechanistic way of recruiting, particularly in volume. So if you don't meet the criteria, you're cut off and you're out. We've done some collaborative work over the last couple of years to really challenge those entry criteria to say, is that absolute? And what does that mean for people who haven't had a traditional education or don't have English as the first language? Or, so we've really kind of shifted, and I think, real credit to partner organisations, particularly larger employers, have done a lot of learning from some of our smaller organisations where actually they're much less rigid. So bringing in third sector is a really good example where charities and independent care providers are much, more person-centric when it comes to that recruitment, whereas our big organisations can be a little bit traditional, I think is a fair approach. And they have been very adaptive to that. And I'll bring in colleagues to comment a little bit further on that. Just finally on the workforce indicators, particularly around disability, we are starting at quite a macro level to try and understand some of the numbers across the city. So it's not something that people necessarily record in equivalent ways. So the data is quite complex to map across the different organisations. But what we have been doing, again, linking back into third sector, is working with organisations who are specialists in these areas. So think Lighthouse Trust and other organisations who've got real expertise that they can bring in and help us connect the right people together. And one of the reflections we've had recently is, rather than referring people on to specialist support, is bring the specialist support in around the person, so connecting back in rather than passing people off. And I think that's it's an important way of framing the support we provide in Leeds. So still lots to do in that space, and we haven't yet got a clear picture of numbers. We know that there are issues with people's willingness to declare disability once they're in work, and we've still got a relatively large number of people who choose not to report a disability. And we know that we've got lots of people who are not yet in work, but might have multiple reasons for not being in work, and the recording again there can be challenging because they might be recorded as not being in work for one reason, but actually as we go through career coaching in the Talent Hub, we find out that actually there is a disability, there is another issue that needs support in that space. So a lot of work to do.
Yeah, thank you very much. And just to reiterate, if it wasn't clear, it's a fantastic initiative and congratulations to you, and hope it continues to bear fruit.
Chair, could I come in just to add? So what I think is fabulous about where we are in Leeds with the Academy is the Academy fills a space where we're better together rather than separate. So I'm well connected across all of the HR directors in the NHS, and there's a huge amount going on now to widen the participation and access to roles within the NHS. What's fabulous about the Health and Care Academy here in Leeds is that we can have a conversation with talent in Leeds about better fit with all of the roles in health and care across Leeds, whereas what I find with my colleagues elsewhere is they might well still try to help somebody fulfil the requirements of a job for an acute trust when actually they would be better working in a different part of the health and care sector. And that's just some of the sort of real value add that Kate and the team bring. So that's, I think, the bit that's unique for Leeds.
Great, thank you. Can I just turn off your microphone? Thank you. Cheers, Jenny. Thanks for that. Okay, I'm going to bring in Jonathan next.
Thank you, Chair. It's really exciting what you've described. Very, 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 very innovative, and having worked in other systems where that's not happening, I can see what the potential is. One of the areas I was wondering about was how much people who are delivering a service on a day-to-day basis know about it. So, for example, maybe a GP who's working with somebody and thinks they've got real potential, would they know about the talent pool? or a social worker who's working with somebody with lived experience around disability or learning disability, would they know that that's an opportunity there that they might be able to refer to? So I just wonder how well known the whole thing is within the kind of service providing community within Leeds.
So growing, I think, is the answer. So you can see through some of the kind of data reports that we have got a reasonable reach out into the different types of organisations in Leeds. So, for example, the Learning Portal has over 5,000 of our 60,000 workforce who are now regular users of the Learning Portal. These are people who work in health and care who can access that training through the academy. And they come from the full range of types of organisations, so GP practices, care homes, home care providers, NHS trusts, charities, etc. I think what we've seen is where we do proactive work to promote and engage is where we then get a big uptick. So over the last year, we've done quite a lot of work with children's services, and we've seen where we've had a real problem to solve in terms of recruiting or something like that. It then has a ripple effect. So by engaging the right people in those conversations, then the word of mouth spreads, and they then share that with colleagues. And it's not just about recruitment, then it's about, you know, did you know that there's training available? Did you know that there's other support you can provide and access? So we've got key partner network organisations that we regularly talk with and engage with, so the GP Confederation, Leeds Care Association, and others who provide a really good networked way of reaching out. I think the areas that we haven't got such strong connections with, particularly at the moment, are primary care pharmacy, for example. So reaching out into that feels like an area where we've definitely got opportunity to do more. And then I think there's something around actually in our larger organisations, how we get deeper into the organisations. So it may be, I talk about Leeds Teaching Hospital work very closely with the academy, but it's a section of Leeds Teaching Hospital. It isn't necessarily the ward sister on such and such a ward who would necessarily access those. So I think we've got more work to do in penetrating deeper. But Jenny and Caroline might be able to add to that.
So a couple of things. I would definitely say it's developing, but quite quickly. And I think we've got a real opportunity with the Career Compass to sort of speed that up. So I will use in Leeds Teaching Hospitals, for example, and I know some of my HR colleagues in some of our other statutory organisations will promote the talent hub to those that have got sort of workforce roles within the organisation. So, for example, the talent hub is now working with the team that are setting up the new Aseptics hub, which is a large pharmacy-based service that Leeds is hosting on behalf of West Yorkshire, and will use the talent hub to help us staff that from local areas and work very specifically with Kate's team in order to be able to just connect the opportunity with the talent that exists in Leeds. So I would say certainly in my organisation I've seen that sort of strength of depth and the impact that is having be much improved over the last 12 months, which has been really good to see. And it's been the workforce leads in the main that have then been able to make the connections with those that are recruiting and that are looking to recruit and retain from Leeds as a place.
Yeah, Caroline.
Thank you. If I could come in from a sort of social care perspective, Kate started by saying that we are in a much improved position around recruitment, and I would say that that's absolutely the case
for our wider social care, so that is our external providers of social care services. We still have quite a few issues around our own professionally qualified social work and OT staff within the council, but wider in the market for social care, there's definitely been an improvement. But I think one of the key issues that we're experiencing now is not the recruitment of the workforce, but the retention of the workforce and the support and development of the wider workforce. And we have a side issue, probably not as huge in Leeds as it is in other parts of the country, but there is international recruitment, which is causing difficulties in terms of revocation of licenses for providers who particularly deliver home care, who are then bringing people in to the country, offering them employment, and then not really being ethical employers, and those people then being displaced, and we're having to follow up and pick up on that. So that's one of the areas. But I think the focus isn't for adult social care, wider market isn't so much around recruitment, but it's about retaining the workforce, it's about the fair pay commitment, and it's about training and support and career progression, and a little bit more of the concerns that we've had previously around a level playing field around, the value of the social care workforce relative to the NHS workforce. And that's some of the areas that we're picking up as part of the One Workforce Leeds work that we're doing.
Super, thank you very much. Jonathan, do you have a follow-up question? Great, thank you. Okay, going to bring in Councillor Hartbrook next, please.
Thank you, Chair. I think everybody in this committee would agree that the underpinning of the NHS is its staff. I think many, as was answered in the previous question, we are subject increasingly to international pressures in terms of staff retention, and it's really good to see an initiative like this that is bringing people in from the input end, and also that we're acknowledging the work that needs to be done to prevent loss and attrition at the other end. I've got friends and family who work for the NHS, and it's really good to hear that attitude is in primary consideration, because working for healthcare is a vocation. It's something, many people who have the aptitude to work in care or the NHS could probably earn more money doing other careers or professions, and it's a credit to them and the nation that they choose the career that they do choose. I'm particularly interested in terms of outreach and how we bring people in, and I know, for example, some organisations do things like degree apprenticeships, particularly in retail and some other areas, and outreach to schools. And also, because my own cousin went through this route, although quite inadvertently, moving from a caring profession, basically in home adult care, into the NHS, which is quite an interesting route, and whether it's so particularly interested in how outreach has been done with, or if any is being done or planned to be done with schools, and then also kind of people who may be in a comparable profession or a relevant profession with the right skills and attitude, the right attitudes, even if not currently all the right skills, are being attracted in. Thank you.
Thank you. So I think outreach is a real challenge to coordinate, because I think all of our organisations are active in outreach and working with communities, working with social groups to try and encourage interest in careers in the NHS and the wider social care sector as well. So what we've been doing, I guess, to highlight a few things, is we collaboratively we have a network which brings people together from employers and education partners to try and think about how we do some of that together. We work with the Leeds Learning Alliance in particular, which is a representative body for schools and colleges across Leeds, to be able to try and coordinate that opportunity. And I think one of the key things we've learned is around focus as well. So we need to focus our disproportionate effort into schools that wouldn't get support in other ways. So that's part of the health equity agenda that we're really trying to build into all of the activity that we do. Over the last couple of years, I think we've seen some real potential growing in the space of collaborative apprenticeships and in T-levels, collaborative T-levels. So, as I mentioned before, but Leeds is one of the only places in the country that has a collaborative T-level offer in health, where we bring social care, healthcare providers together, and we provide opportunities for placements across a range of sectors, and both the college and sixth forms work together to make sure that the individuals have the right opportunities for them. So we've been sharing a lot of that learning with the Association of Colleges and other organisations nationally to try and generate some of that, the benefits that really does bring, particularly from an outreach perspective. Apprenticeships is a really interesting one that I think will be focused on more over the coming couple of years. So we, at the moment, I think we've got a good basis for collaborative apprenticeships across Leeds that help people take less linear pathways into health and social care. So there's very few people who at the age of 16 think I'm going to do a level 3 apprenticeship, then a level 4 apprenticeship, then a level 5, then I'm going to be a nurse, and then I'm going to specialise in this. It's much more likely that they'll take the first step and then look at where that might take them. So we're trying to work with all of the partners on that journey now to create apprenticeship pathways in Leeds and create better capacity with our training providers and with our employers to plan that and be clear about what are the roles that are going to be needed in 5-10 years' time in Leeds, and how can we plan capacity and build capacity in apprenticeships across the right settings. So it was a little bit like the earlier conversation about, can you just take money out of the NHS and put it in somewhere else without that creating too much disruption. And apprenticeship and training provision is similar in that sense. So it's more about building that incremental shift and saying, actually, at the moment, this proportion of our investment in 16 to 19 education is in this space. We want to start to expand in this space, so let's see how we can adapt provision. But we've got a good kind of network and a project group working on that at the moment.
Super, thank you very much. Okay, I can't see anyone else indicating at this point. No, great. Thank you very much for this report. Really positive, and it feels like good progress moving forward. So thank you for that. Yeah, it's really interesting how the developing side about getting the more knowledge out there. So hopefully there'll be more of that next year if you come back again. So thank you very much. Okay, I'm just going to, because we've been going for a good period of time, I'm just going to have a 10-minute adjournment. So we'll start back again promptly at 3:25 according to the clock at the back of the wall. So, and we'll move on to the next item then. Thank you. Okay, right. Welcome back, everyone. Thanks for coming back. On to item 9, which is Leeds Health and Care Resilience and Winter Planning. Firstly, I think we've got a couple of new people around the table, so can you go introduce yourself? If we start with Helen, thank you.
Hi, I'm Helen Lewis. I'm the Director of Pathway and System Integration for the Leeds Health and Care Partnership. I'm going to introduce my colleague Helen.
Hi, I'm Helen Smith. I'm Programme Director for the ICB in Leeds for same-day response, urgent and intermediate care.
Hi, my name's Dawn Bailey. I'm Consultant in Public Health, Leeds City Council.
Hello, I'm Hannah Sowerbuts, Head of Health Protection at Leeds City Council.
Thank you. Okay, Councillor Venner, do you want to introduce this item?
Yeah, I'll be really brief. So this is a report on winter planning. It's very much a team leads report, as is reflected by the people who are presenting it. It includes preventative measures as well as responding to emergencies, and very much reflects our partnership approach, which is demonstrated by the fact that it's a report that's by Helen and Dawn. So planning for winter is not only about what happens in the hospital, although that's really important. It's also about what public health are doing, what happens in the communities. There's really strong reference in the report to the third sector, the neighbourhood networks. So it's very much illustrating the way we handle all challenges, which is in a strong team leads partnership. So with those brief comments, I'll hand over to Helen and Dawn.
Thank you, Councillor Venner. So just to echo that, we wanted to focus on winter preparedness, which is obviously for the population, not just for the organisations. Each organisation, all of our statutory organisations, will have their own capacity and demand plans assured through their own boards, their own decision management tools, their own escalation for when capacity and demand are out of sync or when there are particular issues. So it's not the purpose of this agenda item to bring that detail, but what we wanted to do was bring the breadth of the work that we do here so that members are aware of the context, and we'd really be grateful for any help or support you can provide in encouraging some of the proactive actions for your constituents, especially around vaccination. We wanted you to be aware of the system risks. This is not going to be an easy winter. There will be a huge national focus on quality and safety, which you would also expect that we would be as keen to have as anyone else. We're all really aware of the impact of long waits on the outcomes, both for people in A&E departments and for the ambulance service. But as Sam said earlier, we're also really keen to do what we can to prevent people's healthcare deteriorating to a point that their care can only be delivered in a hospital setting. I'm going to refer you to the list on page 69, where we talk about the key elements of the plan and what we are focused on through that plan. And I'm just going to assume that colleagues have read the paper. I suppose the thing I wanted to say that's subtly different from last year, the main difference is that we have a new vaccine for respiratory syncytial virus, primarily for an older cohort and for pregnant women. That will be not without its challenges. It's a brand new cohort, it's a brand new virus, it's a brand new vaccine. And so there'll be some rollout questions around that. So that's different from last time. Last year we talked about the risks of industrial action. There are still industrial action issues in the system, which we probably need to not forget. And then obviously the significant financial constraints across all system partners are part of that wider context. But rather than doing anything else, we're very happy to take questions. Dawn and Hannah are here, and they're the particular experts around the proactive, the public health elements of the plan and the vaccination plans. And Helen is the person who's pulled together the details, so she'll take the difficult questions. Colleagues here from LYPFT and LCH as well. So we're just happy to answer questions that members may have.
Super, thank you very much. I really appreciate this report, and I appreciate all the data. I think after last year, it's much improved, so thank you so much for that. I like particularly helpful things like the non-elective readmissions graphs. I think are really helpful. I know Councillor Ritchie asked a bit about this earlier. I guess the flu, like the vaccine uptake around certain groups, I think that's deeply concerning. I wonder if you can comment about that and anything we can do around that messaging, and then I'll open to questions from members as well. Thank you.
Yeah, I think we're going to. Yeah, do you want? Yeah.
Thank you. So obviously NHS lead on the rollout of the flu and COVID vaccine programme, but as partners and as a public health function, we work to ensure that we can improve uptake, particularly for those cohorts with lowest uptake in areas of deprivation and for those people most at risk. As a system, we've worked together to attract funding into the city to support some of that uptake, including working with community approaches, but also outreach clinics as well. We've done a lot of work locally with the data, so we properly understand who's not getting the vaccine, and we're working with third sector and communities to understand barriers to coming forward for the vaccination. So we have a lot of local intelligence, we have a lot of activity, we've levered in some additional resource this year as well. So we are very aware that there are cohorts where we need to increase uptake. What I can say is for those cohorts who are particularly most at risk, so particularly residents in care homes and over 65s particularly, we work really hard to ensure that we've got really good uptake. And last year, I think we achieved around about the 80% uptake for care home residents, for example, with really low numbers of outbreaks, both for flu and COVID. So we know there are areas we have more work to do, but we are also confident that where we do have the higher risk, we are able to ensure that we have good uptake to protect people.
I think it does go back also to awareness from colleagues. So if there's anything that councillors are able to do through their own communication challenges, through channels, through their own Facebook groups, whatever it is, it would be really helpful for colleagues to be aware and share in that messaging. This is not an NHS or a local authority kind of responsibility. It really is everybody's business. So anything you can do as individuals would be really appreciated. Sorry, Victoria, did you want to?
Yeah, thank you. Just to add one overarching comment, I think there was a lot of learning that we did through COVID with many people around this table on how best to increase our vaccine uptake. And one of the really critical things it feels for this conversation is that so much of it is around how we organise, how we deliver our vaccinations as a system, and how we go to where people are and how they live their lives, rather than expecting people to come to how we organise ourselves and the NHS organises itself, which often doesn't fit in at all with people's lives. So I think that we need to be really careful around understanding the small proportion of low uptake, which might be down to people not feeling confident around the vaccine. But all of the evidence and all of the learning from COVID is that really is a small portion. We need to be really proportion. We need to be very careful that we don't over-attribute to vaccine hesitancy when actually we as a system are not going to where people are and how they live their lives. So it was just a word of caution, really, not to interpret this as a sort of a public lack of confidence. We've got lots of examples where we could do a lot better in delivering the vaccines in communities and in places where people live their lives, and I think that has to be the starting point. So just to kind of make that comment around the approach we would want to take. Thank you.
Thank you very much for that. Okay, I'm going to bring in Councillor Buckley.
Thank you. On page 82, item 6, access to and flow through mental health services, you talk about there being 100% capacity here and people needing hospital care out of area, sometimes at considerable distance from Leeds. When they are discharged from these areas, do any patients slip through the net on return to Leeds? And what safeguards are in place or could be in place to ensure this doesn't happen?
I'll pick that up and respond. So for every service user that we place in an out-of-area bed, we have a very rigorous monitoring system in place. So we know exactly where they go. We have senior clinicians who liaise with those providers to ensure that we're satisfied with the therapeutic input that those individuals are receiving, and where it's appropriate, we aim to repatriate those people to Leeds as soon as is feasibly possible. For those that stay for the duration of their stay out of area, We liaise with them around discharge planning to ensure that there are robust plans in place for when we do bring them back to Leeds. So I'm fairly confident that we don't have people that slip outside of the system that we have. Occasionally we do have people who present for an admission in other areas of the country unbeknown to us, but generally once it becomes known that they're known to mental health services, usually those providers in other areas contact us to put those arrangements in place that I've described. So I hope that provides the assurance you're looking for.
Yeah, can I just ask another question then, please? What happens, for example, if one of the members of staff in another area leaves the group and passes on the information to another member of staff? Is there a guarantee that they will continue the care of this patient from when they return back to Leeds? I haven't made myself clear on that one.
So,
what I'm saying is that when people, say for example, if they were in Birmingham and the member of their key member who was looking after them left, are the safeguards in place there for other staff to take over? And
there should be. So there should be clear documentation around the care of any, whether it's a mental health patient, a community patient, or an inpatient in an acute hospital, about the care that's being received and the arrangements that are in place. We do experience changeovers. If somebody was out of area and then they were coming back to Leeds, they may not go back to the same team. It depends on their individual needs at the time of transfer.
Thank you very much. Okay, Councillor Hartbrook.
Thank you, Chair. Thanks for sharing this report. It's really interesting. I'd like to direct everybody to page 72 on the vaccination uptake, because there's some fascinating information in there. I think the sample was taken, or the report was taken in February. So would it be fair, first question is, would it be fair to assume that everybody who would be interested in having a vaccine would probably have had one for that year by that point, because most of the vaccines tend to be done in the run-up to Christmas, I believe. So where it says still to do, would it be fair to say that's more of a missed for this year, catch them next year, hopefully? I'm also querying on the Orange Box overall uptake, 50.2%. I may be doing the maths wrong, but I think it looks to me as though you've taken all the percentages as percentages, added them together and divided by the number of percentages you've measured, rather than weighting them by size of cohort. I might have got that wrong, but I came up with an overall percentage. If you added everybody who was eligible and everybody who took it up, nearer to 30-35%. But it's hard because some of the numbers are not in there, are not comparable. But if, for example, you take the eligible 76,000 completed 21,000, which are 27% uptake, that would massively overweight the overall percentage. Whereas the 72% or 76%, which are cohort against the cohort of 77, can't really kind of add those percentages together and get that's how it looks. But I'd be just curious as to whether you can just double check the maths on that. And also I noticed the lowest cohort is pregnant patients, which I think I can extrapolate in my own head why that might be in terms of fears, misunderstanding, and some of the social media stuff that people see around vaccines. And I think that underlines something that was touched on earlier on around, you're asking about members giving support, and I think many of us gave support in terms of encouraging uptake of COVID vaccines in what seems like a lifetime ago now. And I think views on vaccines have sort of entrenched in some ways, in that people have kind of made their own minds up against them. My own view is that while people may go, I don't need a vaccine, I think one communication potential that could be useful is, you may not need it, but who are you coming into contact with who may benefit from you? And I think to me that's a bigger driver to say, this isn't about protecting you, it's about protecting your gram. That kind of message. But I'm also very aware that a lot of the messaging that was put out around 2020 around vaccines in 2021 has left a lot of unfairly mistrust and misinformation kind of lurking in the nether regions of the internet. Thank you.
Thank you. I don't have the data here clearly to hand to check the maths. We will check it and come back to you, Councillor Hutbrook. I think that's the best thing to do. I want to draw you back to Victoria's very strong evidence base around the difference between hesitancy and access. And I think while there may be some hesitancy, if we haven't gone and stood outside people's doors and said, would you like a vaccine, we probably can't assume that. I don't know if we've got any more evidence around pregnant women. I'm guessing that pregnant women feel they're more healthy than, but Victoria may have an answer about pregnancy.
So just to comment and add on that particular statistic, the low rate of vaccination uptake in pregnant women is exactly a feature of the point I was making before. So we've seen this drop, not because we've got any evidence of more vaccine hesitancy in pregnant women, but because the services that they get now in NHS maternity services have been centralised, and the appointments they're given don't fit with when they need a vaccination. So they just don't line up. So it's harder work for pregnant women to then go and try to get a vaccine when the system doesn't naturally support that timing. So it is a classic system issue that we're working on at the moment. So there may well be many pregnant women who are nervous of the vaccine, but the consensus is that the reason why we've seen that drop is because we've not lined up services with the prevention offer, including vaccination. So we've got some work to do there. Thank you.
Thanks for that. Do you have follow-up?
Yeah, just briefly. Yeah, I'd concur with that, Victoria. I mean, my own GP surgery has had quite a good campaign in terms of pushing out emails to say, hey, I made it quite easy to sign up to a time and slot that suits you. And I also noticed one of the local pharmacies in Rothwell pushed out on social media, we've got the vaccines, pop in, no appointment needed. So that, I think more of that across the city would be welcome. So that, and we did a lot of it during COVID, didn't you? We made the appointments easy to get. So I think entrenching that would be really, really good. Thank you.
Yeah, thanks for that. Thanks for that line of questioning and those answers. I think that's really interesting around getting the vaccine to the person. And clearly, it's harder to travel and get places when you're pregnant as well. So it makes that if you make it more difficult, I can understand why you might not. Okay, I'm going to bring in Councillor Taylor next.
Thanks for the report. It's really good. But following on from Victoria earlier when she says is how you sell the vaccine, I'm going to talk about the Bay and Black Nation community. They still had the myth from the COVID, which they wouldn't take the vaccine, as you know, and it was, I know myself and Councillor Salma worked really hard to get the Bay and Black minority out to get the vaccine. However, it still stands in the Black Asian community as we speak. Even till today, if someone died, they're convinced it's the vaccine that affected them. I speak to quite a few people at present, encouraging the elderly to get it. And the question I'm getting, why do I need a COVID vaccine? Are there COVID? They receive a letter or text from their doctors, come and get your COVID and flu vaccine. Flu vaccine is not a question for them, but why are they having it? So it's how you get the message out there, why they need it, why they should continue have the COVID vaccine. And it will be a challenge. I don't know if you keep data and if a Black Asian going forward for their vaccine, that would be really good to see if they're still taking it on, because that was the big issue during the pandemic. So if we need to deliver it, we know the goodness of it, but the question, they don't understand. So it's not they just coming to take it, it's how we explain to them the reason why.
Yeah, I think what you're saying is there's a public information thing as well as an access angle. I think that's what you're saying, and I think colleagues are recognising is both aspects. It's being in the right place, but also understanding the benefits to yourself and your child, and your family. Yeah, good. So I'll take that as a comment unless you want to add anything to that, Victoria or Dawn.
Just 100% agree, and absolutely would work with everything that you just said, and that is the approach that we've taken over the last few years during COVID, learning each year, and obviously want to apply that for this winter. Happily have a conversation outside of here as well.
Great, thank you very much. Okay, I'm going to bring in Councillor Ritchie.
Thanks, Chair. Just on page 71, I'm kind of surprised how low the NH Trust staff vaccination take-up is. I wonder if there's any explanation for that. And then a comment around the delivery, certainly from last year, and an experience that a pharmacy told me they had, is that the booking system, the NHS national booking system, didn't marry up with the ordering system. So you'd have patients booked in for vaccines, and then on the day the pharmacy were having to cancel them because they didn't have the stock delivery. That's only one pharmacist who gave me that example, but it suggests there might be an issue there around connectivity, and we've heard all about the digital and all the joining up, so some assurance around that. I totally get what you're saying, Victoria, around us going out and delivering the vaccines where people are, but I think it'd be wrong not to recognise there is some hesitancy on vaccine take-up, and you can see that around the MMR vaccine, the figures there, and that's, I know, at much higher levels, but still there's been a drop. And I see it on social media, and again, I know that's a very small snapshot, but they are repeating misinformation that they're picking up from academic reports, but selecting sections of it to prove, oh, I told you this would cause deaths and so on and so forth. And I've said previously that we need a comeback. I think the tactic has been to ignore it and go away, but I think we should be open and transparent and tell people why they're wrong, that they're not understood, or they're repeating something that's taken out of context on a report, or it's a very small sample, etc., etc., and challenge that misinformation. I think that's the thing to do, and that would give me more confidence in putting my Facebook post out there promoting the vaccine, because my mental health can't take a pile-on of these cynical conspiracy theories, expecting an instant response to tell them that they're wrong. So that's where I am. But I think, as I say, there is hesitancy out there, and we've got to acknowledge that.
So I'm going to start, and I'm going to call some colleagues in. So first of all, I've just redone the maths and realised that there's a massive cohort missing. So although we've given you 3 cohorts, which actually do add up to 30%, it doesn't actually include anyone over 65 other than in a care home. If you add all of those back in, that will be the explanation. So I'm sorry, it's a misleading. We should have put that 50% box somewhere else in the infographic. So thank you for checking. But now I've looked at the sub-cohorts, I believe that's the answer. I'm going to come back to Victoria again around vaccine denial, but I just wanted to pick up. Sam's going to answer some thoughts around the staff uptake, particularly, if that's okay.
Yes, so it's a challenge each year to encourage staff to have the vaccine. We do all sorts of different campaigns, go out to where staff are. I think a couple of things I just bring to your attention really. So because the vaccine is available in so many places, staff often go to their GP, go to a pharmacy, and we don't always have that collected on our system, so we don't count those numbers in. There's a little bit about the aftermath of making the COVID vaccination mandatory. And so towards the end of the pandemic, there was a requirement for all staff to have the COVID vaccination. A lot of pushback on that, and I think there's still an aftertaste from that. And I think the other thing is that the vaccine did its job around COVID and divorced the really serious illness from having COVID for healthy populations. And people think, well, I had COVID, it was okay, I had my first batch of COVID vaccinations, and COVID is just another thing that I have over winter now, and so people don't see it as important as it was. But of course it is, because it's not just about protecting yourself, it's about protecting those around you and your patients as well.
Sorry, there was one other thing you asked about. You asked about supply chain. I think the way that pharmacists order vaccine, and indeed general practice orders vaccines, is somewhat at the risk of the supply chain. So even if the booking, they're just two completely separate systems, and even if you've ordered your vaccines well in advance, they don't always show up. So I don't think it's a digital interoperability issue. I think it's a supply chain issue, that the vaccine supply chain last year particularly was not always reliable. Colleagues who are closer to the detail of why supply chain is unreliable would be able to give me more detail, but I don't think even if we had the best interoperability in the world, it would solve it, because they're just two very different systems providing supply and booking appointments that have different constraints in their thing. But I agree, it's incredibly annoying, and if you turn up once and there isn't any vaccine, why would you come back? So I recognise, I also just saw a post of someone who turned up and said, oh, there's no vaccine. Why didn't anyone tell me? So I appreciate that. I think there's probably more work to do, and I can check on what the supply chain looks like this year. I'll come back to you on that. Victoria, did you want something more about hesitancy, or at least about challenging conspiracy theory?
I'll briefly comment. Thank you, Helen. So I do agree around the need for really clear and simple messaging around why the vaccine is a good thing and how safe it is. I mean, the evidence is so compelling, and it's historically one of the most effective public health interventions ever across the world. So we've there's a lot to go on there, and the messaging that we did through COVID, I agree. We need to keep that going post-COVID, and as Councillor Taylor said, and actually kind of have different ways of communicating with different groups of people around it. So I certainly wasn't meaning to say that that's not an important thing to continue to do. But at the same time, if we make sure we make it easy for people to come forward as well, I think we absolutely have to do both. And I think that it's up to us to get that across in the clearest and simplest language, at all times. And I think it is just such a perennial challenge that has gone on for decades. When I first came to work in Leeds in the late 90s, it was in the wake of the Andrew Wakefield autism kind of publication around MMR, and we employed people to go out there and reassure people it was safe to get your MMR at the same time. So there's often a different version of people's nervousness around this. So just to agree with your comments, I think we need to keep that going, as well as look at the system stuff. Thank you.
Great, thank you very much for that. Okay, Councillor Francemeer next, please. Yeah, okay. Councillor Bromley.
Thank you, Chair. It's been mentioned a couple of times about asking really for our help in sharing that information within communities, and I wondered if, in terms of combating misinformation and looking at a really good visual aspect, do we have something that we could share, like as a video clip, onto our community sites? And if that is a thing, if that could maybe be shared around for our members here today as well.
If that was in relation to flu and COVID, we have quite a few resources that we can share. We've shared a few in the last few weeks, but happily share them with yourself.
And tying in with the flu vaccine as well. So this is like a really good time as well to look at uptake and communicating across our community sites. Maybe there's something that we can use to kind of avoid really that sense of back and forth in conversation that we'll probably likely find anyway, that there's something that's just putting the straight facts out there. I'd really welcome as much information as possible being made sure that we
can get some information to you.
Super, thank you very much. Okay, I can't see anyone else indicating. Oh yeah, Councillor Hartbrook, do you want to come back in?
Yeah, it was just a small point. It's really just re-emphasising something that Councillor Ritchie said around the kind of the mental health toll in terms of taking on the internet misinformation. And I think that just, because it really chimed with me that, because I was very outspoken during COVID in terms of combating that and put an awful lot of emotional effort into it. And to be quite honest, I haven't got that battle in me anymore because it's hard work. And actually they throw up yellow cards, they track you down, they come back to you with arguments, and it's wearing. So I think that actually there's a cohort probably of 20% of people that you're never going to reach. There's probably 80% that can be if elected members and others people who care about it have a convenient here's everything you need to know that may kind of counter. That would be really, really welcome, because I'd be happy to share that. What I think many of us would not be willing to do is to go into kind of full battle gear on the internet against a highly misinformed but very highly motivated cohort of, can I say it, nut jobs.
Trolls. Thanks for that, Councillor. I'll take that as a comment. I think the comment around managing social media is a really valid one, and I think particularly in our roles there's often a challenge around managing expectations on social media, and it's one of the things that astounds me always is how much energy some people seem to have. It blows my mind. I certainly wouldn't have that much energy to push a cause. So there must be something in their belief that there's something in it, and so that's why it makes it challenging for us as councillors, but us as a system in terms of health messages. Okay, so thank you very much for coming today. I think that's a really helpful report, and we've enjoyed reading it, and thanks for answering our questions. I'm going to close that item. Yeah, I think you're welcome to go now. We're going on to our work schedule item, which is obviously a public meeting, so you're very welcome to listen in if you want to, but you don't have to. Okay, so just moving on to item 10, I'm going to assume everyone's read the report and seen the schedule. I don't know if anyone's got any comments or anything else on the work item that they want to raise. As set out. So if there's no comments, I'm going to take that as board agreement for our work programme over the next few months. Super, thank you. So with that then I'll close the meeting. Thank you everyone for your time today. I've enjoyed today's meeting, enjoyed everyone's input, so thank you very much. Have a nice evening.